Hello, everyone, and welcome to Ortho NorCal webinar series. My name is Leah Rutinov. I'm the marketing coordinator at Ortho NorCal, and I'm honored to host this event together with Dr. Nicholas Abidi, Ortho NorCal total joint sports medicine and foot and ankle surgeon. The presentation that Dr. Abidi is about to present is intended for patient and healthcare professional education. If you have any questions, you can direct those to us using Q&A button on the bottom of your screen, and those will be answered after the presentation during our Q&A session. If you have any additional questions after the webinar, you can always email us at marketing@orthonorcal.com or call 408-412-8100. With all that being said, I'd like to introduce today's panelist, Dr. Nicholas Abidi. Welcome, Dr. Abidi.
Thanks, Leah. I just had to unmute myself there. So thanks for attending today. I guess we're all getting used to doing more and more Zoom education, more remote learning, which is good and bad. But thanks for attending. Also, I want to thank everybody and recognize that today is Pearl Harbor Day, and to remember those folks who were involved with Pearl Harbor. So last week I had a World War II veteran who actually was in the service during World War II, even though he wasn't involved in Pearl Harbor itself. Pretty amazing guy in his 90s. So I really appreciate everything those guys do for us. So today we're going to talk about the modern management of hip and knee arthritis. I've been in Santa Cruz for 20 years. I was at the Rothman Institute prior to that, from 91 to 97. We have total joint centers at Dominican Hospital in Santa Cruz, as well as El Camino Los Gatos. I'm also an editor for Journal of Arthroplasty and for Journal of Bone and Joint Surgery, and sit on some panels nationally for peer review. We've also developed some outcomes data for total joint replacement that we'll talk about a little bit. So today we're going to understand both the conservative care for arthritis, for hip and knee mostly, including medication, exercise, and weight loss, and understand the indications for surgery, including just pain, but also what's the loss of function. So when function declines, we look at what are called patient-reported outcomes data, and we're actually following that information on patients on a visit-by-visit basis and compare that to national standards and baseline scores to determine when a patient's not functioning like they should for their age group. Sleep is an issue also. If patients can't sleep, we don't want that because it leads to many other issues. The thing that we're going to talk about a little bit more today too that may be unique in this conversation is what's involved in the pre-op evaluation. We're getting ready for surgery, not just for a total joint, but looking at patients' individual, both reversible and non-reversible comorbidities, meaning high blood pressure, diabetes, cancer, blood thinners, special needs. So our research and our data that we publish actually focuses on those issues, is getting people ready for surgery, not treating everybody the same, but looking at their individual needs and making sure we can risk adjust them and tune those things up ahead of time. So we'll talk about hip replacement, the posterior approach, the anterior approach, the direct anterior minimally invasive approach a little bit, and also talk about the types of knee replacements involving regular knee replacement and then robotic ligament balancing type knee replacement, partial knee replacement. We'll have time to cover those topics. So orthopedic training is 5 to 6 years long, so we're not going to be able to cover that in 5 to 6 years. We have about 40 minutes today to cover these topics, and you'll be able to answer your questions at the end. So what's the conservative care for arthritis? The first thing is to make sure that the patient's body weight is ideal, that their body mass index is between 32 and 35 or less. The patients in the US are gaining weight, as we all know, and a lot of patients sit into the obesity category, which is a BMI, a body mass index of over 40. And so that's not really safe to go to the OR because it increases infection and complications like pneumonia, and blood clots. So every time you lose a pound, your body thinks you lost 3. And some patients are able to get their body weight down and treat it conservatively without surgery, actually. So we get them down to a healthy body weight. Patients say they can't walk sometimes or can't do exercise, and that may be true in certain cases, but the majority of them, we can treat them non-operatively and get their body weight down so they're actually in good physiological shape, either to treat it non-operatively and simply get rid of the pain, or have an optimal surgery so that they are optimized for wound healing and for a good outcome. And with that technique, patients are able to go home now much faster than they used to be when they were deconditioned before surgery. We don't want them to be deconditioned. So what kind of conservative care can we do? Exercise like an elliptical device, non-impact form of closed chain exercises. This is what elliptical device looks like. When we look at patients who use this for arthritis, they're able to lubricate their joints naturally and they feel much better. They also get core strength, and they're less likely to fall and have much more ability to withstand ajar, basically so they don't fall. They have much, much better overall body strength. The other is a recumbent bike. So a recumbent bike helps people develop both quad strength, hamstring strength, stretch their Achilles and gastroc, as well as core. The recumbent bike works a little bit better than the upright bike because it makes you stretch on the down tick. Anti-inflammatory medication is basically ibuprofen and Aleve. Tylenol is not an anti-inflammatory, it's just a painkiller. It's a non-narcotic, non-addictive type painkiller, and they're all over the counter. All of these things have got to be cleared with your primary care doc to make sure your liver's good. And anti-inflammatory medication doesn't just kill pain, it actually reduces the amount of enzymes which can eat your joint if it's taken at a prescription level. So actually it is somewhat therapeutic if your body can handle it, but it can lead to GI bleeds if it's taken too much, or kidney failure. The rheumatoid patients, rheumatological autoimmune inflammatory, both seronegative and seropositive, there are medications like Enbrel, Humira, Xeljanz. They're called TNF inhibitors, and they're targeted specifically for those patients who have an autoimmune inflammatory condition. Those things are very helpful to avoid the advance of disease or arthritis in some cases. So what do we do for non-operative in the office? We can do steroid injections. That decreases the amount of enzymes in the joint, and that's mandatory with some insurance and Medicare before doing any type of a joint replacement surgery. It also helps to mobilize patients and get them tuned up with therapy before undergoing joint replacement. Certain lubricants can be used to prevent surgery or treat patients after knee arthroscopy. And then things like platelet-rich plasma. There is good evidence-based medicine now to show that taking a patient's blood, spinning it down, and using their platelets in patients in their 40s and 50s can prolong their joint potentially. And when it's combined with hyaluronic acid, it lasts longer in the joint, but it's not paid for by insurance, PRP, but there is evidence-based medicine to support it. Some mixtures of PRP do have peripheral stem cells, and there are stem cells which are available, but they're non-uniform. So there's amniotic stem cells, there are bone marrow stem cells, but they're basically experimental because there's nothing uniform and no good randomized data to support when to use it and who to use it in. So a lot of the clinics that are out there are being hawked by the FDA to basically limit their usage because it's not necessarily been studied in detail with enough patients. So why is that? Because the goal basically of creating cartilage in the body that you're born with is you're born with hyaline cartilage on the right, which creates less friction, it's more durable. And when we do operations to and your body heals a cartilage defect, it creates scar cartilage or fibrocartilage. It's less durable. This is what happens after a trauma. This stuff peels off after 3 to 5 years, and the stuff on the right is what you're born with, is much more durable. So what happens that, the idea with stem cells and all these medications is try to get people to grow hyaline cartilage. It's really difficult to do that unless you're a teenager and you have almost open growth plates. It's very difficult even with stem cells. Currently, we form mostly fibrocartilage. If we have spots of hyaline cartilage, that's wonderful because it decreases friction. But a lot of athletes go for these treatments and then they wind up with the same problem basically in 4 to 5 years because they're not really forming a lot of hyaline cartilage. Hip arthroscopy can be done before hip replacement in younger athletes when there's spurs or impingement syndrome or labral tears, but it's not really for older patients or patients with arthritis, but it's one minimally invasive modality, which is somewhat conservative for younger people mostly, and people with congenital disorders. Knee arthroscopy, same thing. It's for mechanical symptoms in the joint when someone has a good looking x-ray like this on the right, but yet they have pain and mechanical symptoms of meniscus tearing or isolated areas where they're missing cartilage. We can do cartilage transplant for those patients and fill the patch to temporarily improve their knee function for 5 to 10 years potentially when they have a good looking x-ray like this, but a bad looking MRI. When someone has an x-ray on the right there where it's bone on bone, that's not really designed for arthroscopy. Patients need to undergo joint replacement at that point or just treat it conservatively without surgery. So when we looked at the preoperative evaluation, this is really key. Not everybody's the same. Getting tuned up before surgery involves these items. So looking for comorbidities, we did a study looking at a long list of comorbidities and kind of narrowed it down to things that are reversible potentially. We talked about body mass index. The other marker, which is pretty important, it turns out, is vitamin D levels. We want the vitamin D levels to be over 50 to heal properly for any type of surgery. And the hemoglobin A1C in a diabetic shouldn't be over 7.0 in most cases. And their albumin should be above 3.5. We also look for colonization with a bacteria called methicillin-resistant Staph aureus in all of our patients for joint replacement because it can result in higher post-op issues, and try to decontaminate those patients if they've had a history of MRSA infection. We also track patients' outcomes pre and post-op with WHO's and KOO's junior scores. So if you get an iPad in the office or a piece of paper that has this info or an email about it, it's to track your outcome to see how you do functionally. And what we note with this is that patients, when they come in, are not doing so good pre-op, but post-op between 2 and 6 months, their scores really improve. And then between 6 and 12 months, they're getting back to normal function in just about most of these total joint replacements. We also stop smoking at least 2 weeks ahead of time, if not further back than that. And patients who are on chronic pain medications in general is a bad idea. Narcotics, we try to get them onto Neurontin and Tramadol before surgery. We also use a lot of regional anesthetics, local anesthesia and spinals, which decrease the complication rates after joint replacement in all of our centers. And then post-op, we use multimodal pain medication, including Neurontin and Tramadol. And we found a lot less, 30 to 40% less narcotic usage with the use of these medications, in addition to Tylenol and anti-inflammatories after surgery, along with the regional anesthetics and quick surgeries, faster surgeries, less time in the OR. So the trends in joint replacement is that Medicare expects to see an increase of 200% in joint replacements in the next couple of years, and about 600% in knee replacements. And the patients are definitely getting younger, we think, due to pediatric athletic boom 30 to 40 years ago, organized sports, and they're definitely getting heavier as well. So these things are combining to create more joint damage, unfortunately, across the US. So the question is, what are the symptoms? Basically, it's pain, morning stiffness. In the hip, it can be groin pain or buttocks pain. The knee can be diffuse, typically for knee replacement. And patients who have night pain and rest pain can be either this or something else other than arthritis. Anytime you have night pain or pain when you're not active, you need to bring that up with your doctor because it can be other things. You can also have referred pain to these areas from the spine. And so it's important you get evaluated, not just assume it's your hip or your knee, because you can have referred pain from one area to another. When there's decreased joint movement, though, and startup stiffness and a risk of falling or giving out, it's typically the joint in question that you're pointing at. However, when you're looked at, we always look at the spine, the peripheral nerves, medication issues, inflammatory disease, and the joint in question. So this is a relatively good looking joint on the left. This is a bad looking joint on the right there. And the question is, when do you have surgery? And the old answer used to be wait till you can't take it anymore. And basically this is when PRO scores, the patient reported outcome scores around 50, or 50 to 60, that's generally when we talk about doing surgery combined with the x-rays and the findings, make sure it's the right thing to do. When patients have much more advanced surgery, they have to have bigger surgeries when they have more deformities. So when they have less deformity, they can have a smaller implant. When they have more deformity, they have to have a bigger implant and bigger dissection, sometimes in corrections. So we don't want to go to what's too far. Hip pain can be caused by arthritis, loss of the blood supply, genetic abnormalities, and post-traumatic injuries. So genetic abnormalities are better now. It used to be hip dysplasia. Patients born breech are higher risk of congenital hip dysplasia. And so those patients had higher risk of arthritis as they aged. This is just regular arthritis. It's not hip dysplasia. This is what we see are called cysts. And then these white lines are sclerosis, and then spurs on the edge and no joint space. And so this patient doesn't have developmental dysplasia. It's just a question of wearing out of the hip socket. This is an obvious cause as a post-trauma where someone had a hip fracture and they had a big plate and screw system placed, and the hip fracture led to the arthritis and post-traumatic arthritis. This is how we template and look at a patient prior to surgery with these overlays to map out the leg length and map out the different parts to make sure we're kind of guiding towards which parts we may need in the operating room. So we look at all the x-rays and look at the patient and then use a computer to help us do these overlays to try to target for the best outcome afterwards. So the parts for hip replacement are very similar. The stem is always made of titanium nowadays. Used to be a harder material before, it's not as much anymore. And sometimes we have to use cement, sometimes we don't. The femoral head can be made of ceramic or metal, and the liner is made of ultra-high molecular weight plastic, and the shell is made of titanium. And so most of these things are generally in the population nowadays uncemented, but sometimes with older patients or osteoporosis, we have to use cement. So that's just a dealer's choice depending on the patient. About 500,000 hip replacements done in the US, about 8 million in China need to be done. The traditional incision has been about a foot long in the past, and that's a pretty big blood loss and a pretty big incision. This is a big old incision. This is the back of the hip, the front of the hip, splitting the muscles, splitting the tendons right next to the sciatic nerve. This is a classic posterior approach. Even if it's a mini approach from posteriorly, they have to go through these tendons, which can risk dislocation. So the socket's refitted or resurfaced and titanium cup is placed. And then the femur is kind of milled out a little bit and a stem is placed down the femur there. And this is done regardless of the surgical approach. And then a ball is put in the top and the muscles and tendons are balanced to hold the joint in place. Now, if the tendons are cut in the back of the hip, like we described back in this x-ray for the posterior approach, there's a higher dislocation rate. So the anterior approach doesn't involve cutting those muscles or tendons. That's why it has a lower dislocation rate. Also, anterior approach, we can place these parts at better angles with x-ray guidance. So in a posterior approach, no matter how it's done, you have to have hip dislocation precautions. You can only go to 90 degrees. You can't bend beyond 90 because it's a higher risk of dislocation. Also can't sit in a low chair or a car for a long period of time because you risk dislocation with that activity. So a traditional approach, got to be careful about bending posteriorly because it can pop out. Now there's an old 2-incision approach which was done in the Bay Area for a while. It's been limited now because it created a lot of problems. Nobody does that anymore, but that was prominent in the Bay Area for a while. Mini incisions can be posterior, which still involves cutting tendons, or the direct anterior approach, which has actually been around since 1947. It's not new. It's a French technique. It's been around for a long time, brought to the US in the 80s, and it involves less dissection. So we'll talk about that here in a minute. It isn't just the size of the incision, it's what happens underneath the skin that's important. So we separate the muscles and tendons and push the nerves to the side and go down to the hip capsule. So this is what the patient looks like on the table. Their head's this way. They're on a special OR table, in this case called the ProFX or the OSI table. And we use x-ray guidance to make about a 7 to 10 centimeter incision, sometimes a little bit bigger, sometimes a little bit smaller than that, depending on what we need for the patient. We also use x-ray guidance so we can position the parts a lot more accurately when we're doing this. And there's no routine dislocation precautions in general. We tell patients not to pivot on the hip and not to stand on it, with their full body weight for about 2 weeks or so, just to kind of let things settle in a little bit. And we're not trying to run a marathon here. We want this thing to last for a long time. So we want the parts to grow in no matter what the approach is, to avoid torque, to avoid falling, things like that. We kind of slow people down for about 2 weeks or so. But we use x-ray guidance to position parts. Hopefully it'll lead to long-term survival rates. We can use it on most patients. We try to get them to lose weight, as we talked about. And we do as an outpatient nowadays. Patients can go home the same day or do it in a surgery center. And we can do both hips at once if we have to in people with congenital deformity. But the difference with the old positioning is the cups were very vertical and they'd wear out. And the ASI supine technique, being on your back, you can match the cup position, the part position to the patient the way they would stand because they're on their back during surgery. They're not on their side. And the way this one was done, the patient's on their side, so the cup position was hard to determine, and it can lead to wear and dislocations. So patients with the older approaches were in the hospital for 4 or 5 days. With the ASI tissue sparing approach, they go home the same day or the next day generally. About 20% are using a canter walker beyond 2 weeks, and most people don't need pain meds after the first week or two. It's a lot less requirements. So it's less trauma, less surgery in general. Patients can go back to things like playing golf and swimming and biking between about 1 to 2 months, depending on the patient. I generally like them to wait for at least 2 months just to get the soft tissue settled down there, let the parts kind of grow in, as we talked about a little bit, and avoid torque. And then people really shouldn't run or jump or jog or do heavy sports or manual labor after a joint replacement because they can wear it out. So we don't want them to wear out the parts. So what can go wrong with hip replacements? Any big surgery, things can go wrong. The wound can have a problem in 1 to 2%. We use vacuums in patients on blood thinners and obesity to avoid things like that, little incisional vacuum dressings, which are portable. The blood clot rate in the legs less than 10% with aspirin, and pulmonary blood clots are less than 0.5%. We find that for preventing blood clots, our academy has recommended mostly aspirin and then pumps in the legs. And the higher risk patients may be on Coumadin or Xarelto or Eliquis. And with the anterior approach, dislocation rate's pretty low, but we want the parts to grow in. So we want people to kind of chill for a little bit for about 2 to 6 weeks. So they're not overcooking it. So that's really, for hip replacement, pretty important. So we're going to go on to knee replacement at this point. Again, we'll hold the questions till the end so we can get through the talk. The knee anatomy. Knee has 3 compartments: the kneecap and the inside and the outside, the medial and lateral compartments, as we talk about, 3 compartments. And this is an x-ray of an inflamed knee with avascular necrosis. Patients can get arthritis with enzymes going up in the joints called MMP enzymes. And then they can develop osteoarthritis or rheumatoid disease, or this is called avascular necrosis. So this is a normal x-ray, but a very abnormal MRI showing dead bone in this area. So conservative care involves using injections that we've talked about, steroid or lubricants, strengthening with exercise. PRP is perhaps coming online now for some evidence-based medicine for younger people. And then stem cell injections, so far it's questionable. There's no solid data to support it right now. If you look at a normal looking x-ray, it's got a good joint space mostly. This is a good looking x-ray, could have some bone abnormality like that previous MRI, but the joint itself looks good. So we always get weight-bearing standing x-rays. And if you look at the joint narrowing down, this standing x-ray shows it goes into a bow leg or a knock knee position. In patients with the opposite deformity, we look for rheumatoid disease or a lateral meniscus tear. Most of it we can manage to a certain point until the patient develops that pain score, which drops down to between 50 and 60, and they can't walk as far, and they're having night pain or rest pain, or basically failed injections and physical therapy. So not every x-ray needs to be treated, and not every x-ray tells the whole story. So what happens in between when someone has a good looking x-ray, but an MRI like we showed with that big bone marrow lesion, that white lesion? There's something called subchondroplasty, which works well in some people with isolated bone disease, but not bone-on-bone arthritis yet. So if you look at this, it involves injecting calcium phosphate cement into the bone itself and inflating that lesion that lights up on the MRI, like the one that we showed before. So this is a bone marrow lesion or a soft area in the bone. Frequently it's down here in the tibia, sometimes in the femur. And we target that with a cannula during knee arthroscopy to actually look inside the bone itself and actually inject that material, which hardens up in about 10 minutes. So that's one methodology, and patients are able to walk on that pretty quickly. The other is in younger people, we can transplant cartilage that is donated or harvested from the patient and grown in a lab. But that has to be in a younger person, people in their 30s and 40s. Beyond age 45, the results go downhill in cartilage transplant. The cartilage transplant looks like this. It looks like cobblestoning or this area, and basically a healthy joint except for an isolated area. Once you start to see arthritic fluid and the x-rays change, you can't do things like this. It doesn't work. So what's a knee replacement look like? A total knee replacement, this is metal on the femur, metal on the tibia, and plastic in between. So these are the bearings, and the kneecap can be resurfaced or not, as we talked about. So why do total knees fail? Patients don't like their knee replacements because they're loose or they give out. They're just not stable. And you can also have things like premature breakage, but mostly it's because the knee isn't balanced properly. And when ligaments aren't balanced in 15% of cases, that leads to about a 75% to 80% satisfaction rate across the country. So some of my colleagues who trained me, Dr. Sharkey, Hozak, and Rothman, where I trained, worked together with the guys across the country, kind of define why these things aren't working. And essentially it's because people didn't have the hip, the knee, and the ankle lined up, or it was just too loose. So the knee should have good equal tension, both when it's bent or called flexion, and then also an extension to avoid developing looseness. And so that's done with something called a tensor. This is how total knees were developed, with this ligament tensioning device. So what we've done is taken that further to work with a robotic system, which actually helps to balance it with a robot and comes up with digital technology so I can actually measure the degree of tensioning with both reflective marker system in the operating room. Now, there are 3 or 4 different robots on the market, not just this one. There are other ones out there too. This is the only one that has a ligament balancing technology here on the left called the tensor. But other robots, they do ligament balancing just with little blocks. So there's a couple of them that are out there, not just this one, that are pretty valid. This one helps to make the cuts with the surgeon. The surgeon does most of it. Some of the other robots, the robot does the cuts. But this is a map of how we map out the knee in the operating room. So we take a surface map in any of the robots and look at the anatomy, create a 3-dimensional virtual model of the knee, and then go through the cuts either with the robot or with me doing them with the robot guiding it based on the surgical plan. And this is what the plan looks like of how kind of we want to get to the knee. This is what we put inside the knee after one of the cuts to map out how the femoral components should be lined up, and then basically execute the plan that's mapped out during surgery with the sizes and the bone cuts, the degree of tracking of the knee. And this is individual. Every knee can be different. Right and left knee is different in each patient sometimes. They're not always the same. So it's really, really important that this knee basically individualizes the treatment to a custom knee for the patient. And so this is the femoral component cutting from the top here on the top of the femur. And then looking at the final plan with these trial components where the robot validates that what we've done is accurate, how the way we wanted it, that it's going to match that patient's anatomy and make it safe for them. So they have less incidence of falling and giving way and loosening. So this results in higher satisfaction rates. So any ligament balancing combined with alignment, results in much higher satisfaction rates and survival rates of the prosthesis, and the patient's outcome is better. So when we look at the overall outcome, we've measured this in Australia. And if you look at the slide on the left, it's the robotic balancing versus the literature. The published literature is on the bottom, where you look at about 1 year, 81% satisfaction rate. And the robotic balancing that we're talking about is about 96.5% satisfaction rate. 39,000 patients, almost 300 patients in this one, so not quite the same numbers. But if you are to look at overall patient satisfaction also at 3, 6, and 12 months, the blue line is basically the balance spot, and the red line is the literature data, making a graphic format showing that this is published information from the Australian registry data. So this implant's been around for a long time. The robot's been out for a long time, and overseas that we've looked at it for a long time as well. So that's a knee replacement with a balance spot or robotic type procedure. This is a minimally invasive type partial knee replacement called an Oxford. There are, again, 3 or 4 different partial knee replacements on the market. It's an outpatient procedure. The Oxford's been studied for 28, 30 years now at this point. It's one of the oldest prosthesis known to mankind. And this is what it looks like. It's a mobile bearing partial knee replacement of the inside of the knee, the medial side. So in the lab, when we look at it in the lab and we look at it in humans, it both saves money, plus also creates almost normal biomechanics to that of a natural knee, because you're sparing all the ligaments and not taking anything out, just replacing part of the knee. That's about a 98% success rate, about 1 to 2% revision rate over 10 or 15 years. So when you look at a total joint center, what are you looking for? In our situation, we have Dominican and El Camino have Blue Distinction Centers. We have qualified surgeons, qualified nurses, regional trained anesthesiologists, meaning they can do regional anesthetics, multimodal pain control. We have orthopedic certified nurses, case managers, nurse navigators, and educational class. So this educational class is really key, that you attend that ahead of time and learn and tell them what your needs are. You'll learn about the parts, how many people in your house, how many steps you have, what your needs are afterwards. And we do with Medicare and non-Medicare what's called demand matching. So we have to justify the kind of help that you get at home. So we make sure that we don't overdo it, don't underdo it. So some patients are able to get up and walk right away. They don't need as much help at home. And other folks can start outpatient therapy right away immediately. We also track the outcome scores like we've talked about. That's always important with a total joint center, that they're looking at the outcomes and quality data. So we do that in all these facilities and get feedback right away and when something isn't working, in order to validate that and make sure it works properly. So there's also something called Episode Solutions, which does management of bundled payments, and they use applications on the phone and nurse navigators in Arkansas and Alabama and other places to talk to you 24/7 if there's a problem, or you can use a phone to actually text them and send pictures if you have to. That results in less readmissions. Readmissions can result in infection and complications and other problems. So we're trying to reduce the number of patients having to go back to the hospital. So Dominican has, people talk about Dominican Hospital, El Camino. If you look at the national rate of complications, and here it says basically that Sutter and Dominican both have no difference rates in any of these items compared to the national rate or each other. They're very similar. And they're much lower than academic centers generally, because they're smaller community facilities. So there's less risk of readmission, death, and complications afterwards. Compared to the national rate, there's no difference, and maybe less actually. So I'm going to open it up now to questions, and Leah can put those. There's a lot of written submitted questions, which I really appreciate, which we'll go through at this point. So if Leah, if you want to do that, you can take it over.
Yeah, absolutely. Thank you, Dr. Abidi. We do have several questions to start with. If you have any more questions, please send those over using the Q&A or chat buttons on the bottom of your screen. We'd be more than happy to answer those. So the first question is that I have both iliac repaired, and the surgeon 2 years ago would not give approval for a hip replacement. So I guess the question is, do you know the reason why wasn't it approved, or
what was the first part, Leah? Again, sorry, you said, can you repeat that?
I have both iliac repaired, and the surgeon 2 years ago would not give approval for hip replacement.
Oh, right. Okay, so both iliac arteries were repaired, right? So if the iliac arteries are repaired, that's a bit of a tricky hip replacement. Number one, maybe on blood thinners. So stopping the blood thinners and doing an iliac artery in an iliac artery patient is dangerous, because the iliac arteries can clot off. The other is you have to plan the surgical approach carefully, because you can disrupt that repair, and it also has to mature over a period of time as well. So the repair from the iliac vessel needs time for it to mature. That can take a year or two, basically, before you can actually do the hip replacement. But it's a really complicated and scary hip replacement in a patient with bilateral iliac artery repairs. So definitely have that done at a tertiary care center where your vascular surgeon is available in case any problems arise.
Great, thank you, Dr. Abidi. Next question, is subchondroplasty available for hips?
Yes, it is. Subchondroplasty is available for hips when there's isolated disease in the top of the joint or the bottom of the joint, or if it looks different. A good looking x-ray, basically with a normal joint space on standing, and someone has a bone marrow lesion, either due to medical reasons or if they're younger and they've had a trauma and they basically feel like a deep toothache. Yes, it's been used very successfully for avascular necrosis and for the hip, yes.
Okay, thank you. Next question, how long is the recovery when one is able to drive and walk again?
So what we want people to, at least 2 weeks, they need to chill out. Once they're off of pain medications and they've worked with therapy a little bit and they've got their balance, then they can drive. Really the first step is off pain medication. And generally that's 10 days to 2 weeks, but also getting their sea legs, be able to have reaction times. And that's a minimum of 2 weeks.
Okay, thank you. Next question, what medical items would a person need at home during recovery?
So during recovery, first of all, we set them up ahead of time. Having a single story house or being on the one floor to get in and out of the house is really important. If you can do that, that's really important. Going up, 36 stairs right after surgery is a really bad idea. But being on the first floor is really important. You may need a walker. You may need crutches for the first 2 weeks. We generally encourage that to take it easy. And then people don't really need commodes or other items anymore, like elevated toilet seats with the anterior hip approach and the knee replacement. That also depends on the layout of your house. If you have a really low toilet or really tight, cramped bathroom, then you might need those things. And so what we do again is demand match those patients ahead of time by interviewing them and asking these standard questions that we've come up with, and then come up with a scoring system called a RAPT score and a GMLOS score, which basically justifies being able to order that equipment.
Perfect, thank you, Dr. Abidi. Next question. If a person cannot take prescription pain pills due to untreated sleep apnea, what can be done for pain?
We'd want to treat the sleep apnea because pain medication can, any form, anesthesia or whatnot, will take longer to wear off in a sleep apnea patient. So anesthetics involve using things which sedate you and sedate your respirations in the hospital. And you can't really take that balancing act. The Neurontin and the Tramadol are not narcotic-based pain medications. They generally don't suppress respirations, nor does Tylenol. But if someone has enough pain that they require the narcotics, we really do need to treat that and not avoid that issue and have someone feel uncomfortable after surgery, raise their blood pressure, increase bleeding, or just have a poor outcome. So they do need to treat the sleep apnea. It's not a good idea to have untreated sleep apnea in general, because over the long term, it can create deficiency of your right side of your heart and other complications, including depression and weight gain. So sleep apnea really needs to be treated.
Thank you, Dr. Abidi. So the next question is, I think I'm going to combine these two questions. So what are the worries about seniors having knee replacement surgery, and what is the percentage of seniors recovering from knee surgery?
Yeah, that's a pretty broad question because seniors means me too, since I'm over 55 now, I'm 56. So I have an ARP qualification at the movie theater as well. So I guess I'm a senior also. So seniors it just depends on the individual. We have a healthy 97-year-old we did last week that we talked about as a World War II veteran, the hardest bone I've ever seen in my life. But his physical capability, just because he's 97, is a little bit less than, say, an 87-year-old. It really depends on the individual. We have to look at their medical comorbidities, like we listed. If someone has diabetes and heart disease and has renal failure, they're a high risk. We look at that in all age populations. It doesn't necessarily just have to do with age. Having said that, when patients hit above 85 or so, we try not to treat them surgically because they're not going to be able to participate in the rehabilitation process. Knee replacement's harder to get over because you have to work through range of motion than hip replacement. Hip replacement doesn't require a lot of rehab. You can kind of, go through the walking process and just get better with time. Knee replacement requires a lot more work. So we look at the individual. Generally for hip and knee replacements, when we select patients appropriately, the outcome is about 90 to 95% good or excellent outcome. As we showed those slides, up to 96 to 98%.
Thank you, Dr. Abidi. Next question. What would be the non-surgical interventions one should consider before surgery, assuming symptoms are sufficient to alter lifestyle and produce level 5 pain? Any particular order you would suggest for trial or of procedure?
Yeah. So the patient should have corticosteroid injection, physical therapy, and reversing any type of weight gain issues first if they are outside the norm. And generally, again, we do those pain and function scores and get x-rays and correct deformities. But some patients are so deformed and so advanced that they really can't wait because they can actually, the more your hip is frozen, for instance, where your knee is giving out on you, the chance of breaking your hip and falling and breaking your wrist goes up. So you have to look at that patient and make sure their balance and strength is good, or protect them with a walker, cane, or crutches also. So to decrease pain generally involves oral medication like Tylenol or anti-inflammatories, corticosteroid injections, and physical therapy. And physical therapy and corticosteroid injections have been shown to have the best impact. We only do about 2 or 3 corticosteroid injections. I usually wind up doing 1, frankly, because we kind of look at the response of that patient. And if they're bone on bone, they need to get replaced at some point. We'd rather do it when they're healthy and they can actually enjoy the replacement afterwards. Replacement is not the failure of conservative care. It's more of the next option, frankly, with joint replacement and most orthopedic procedures.
Thank you, Dr. Abidi. Next question. Can a partial knee replacement be converted to a total knee if necessary?
Yes, yeah, we have to do that. So partial knee replacements fail in about 1 to 2% of cases over time, or if someone falls and breaks it, or they develop an inflammatory condition. So last week I had a patient who developed ankylosing spondylitis and pseudo gout about 3 or 5 or 10 years after having a partial replacement as he got a little bit older. So his body changed, and we converted his partial to a total without a problem. That happens sometimes, yes.
Thank you. How many knee replacement surgeries do you do yearly?
Several hundred.
Thank you. How much physical therapy, muscle strengthening should a patient who will undergo knee replacement prior to the surgery?
It depends on the patient. We generally recommend 3 to 5 sessions perioperatively for prehab, but if they're very, very deconditioned, it might be more than that. We don't want to burn all their benefits before surgery, but we want to tune it up and match that patient's needs, and at least 3 to 5 sessions.
Thank you, Dr. Abidi. Next question. Can I get a hip replacement if I had a 14-millimeter rod installed from hip to ankle?
Yeah, that's an unusual thing. So that if you've had a knee fusion from a nail going from your hip to your ankle, that's got to be taken out first. And yes, the hip replacement can be done, but the amount of torque on the hip replacement is going to have to be considered carefully. But that rod's going to have to come out first by whoever installed it.
Thank you, Dr. Abid. Next question. I have been diagnosed already that I need both my knees totally replaced. I'm currently very active and have been my whole life. I surf, mountain bike, swim, and strength train. I'm 54 years old and in very good shape. Will I still be able to do all those things?
The answer is maybe. So the question is, this is a classic question. Someone in their 50s who's really, really active and they want to talk about doing a joint replacement. Your natural knee is always better and more durable than an artificial knee. So if you can do those things and your pain levels are 1 or a 2, we'd like to try to maximize you non-operatively or slow you down, basically. But the majority of patients are able to do things like mountain bike, frankly, and surf and swim efforts because they're non-impact activities. So patients are able to get back to that, but it takes about 1 year to 1.5 years to really get their full function back. And it depends on their deformity ahead of time and really how careful they are in the rehab process. But generally with the ligaments that we're talking about, or the partial or total knee replacements that we're talking about, the ligament balancing, it's not the end of those activities. It can make them better, but you can still wear out the artificial parts like you wore out your natural parts.
Thank you, Dr. Abidi. Next question. I muted myself for a second and forgot to unmute. Next question is, what determines the use of cement versus no cement in securing the prosthesis after the removal of the femoral head? The age, sex, male versus female, tissue, sample of bone, or other?
Right. So the question is whether we cement or not, both with knee and ankle and hip replacement. So I'm going to talk about both of them. So for hip replacement, we generally don't cement, but we have to if someone's canal is big. And also if patients are over 80 and they have a large canal, the incidence of hip fracture after falling is 8 times higher in uncemented prosthesis. But there are people with really, really good bone in their 80s and their 90s, like the one we did last week, where you simply can't cement them because the canal is too tight. And we have parts that we use that take that into account that are more modern and are called fit and fill prosthesis rather than blades. So there's less likelihood to have a hip fracture with that. So we look at the bone quality. As far as knee replacement goes, younger people in their 30s and 40s can undergo uncemented knee replacement. The recovery is longer because it takes time for the parts to grow in. They have more pain after surgery and more bleeding and more swelling. Cemented knee replacement's been around for decades. And the theory is in people in their 30s and 40s, they might loosen up the cement by the time they're in their 60s or 70s. That's okay. That's, getting 40 years out of it's pretty good. And the panacea in running for uncemented knee replacement really hasn't been proven, and it's still debated in some circles.
Thank you, Dr. Abidi. Next question. What criteria determines the duration of physical therapy, and are there any pre-op physical exercises that might benefit the patient's recoup time?
Yeah, no. So the prehab that we've sent patients for both hip and knee replacement, your physical therapist will assess you and assign you some exercises. Basically, it's involving balance and strength and normalizing your gait as much as possible so you don't fall with or without surgery. So it's important to work on core strength and the way you walk, your quad strength, your hip rotators, and essentially, again, with the help with the anti-inflammatory medication or corticosteroid injections, improving your balance. It definitely improves the post-op recovery and shortens the amount of therapy that you need after surgery.
Thank you, Dr. Abidi. And the last question, how do you decide whether to do a full knee replacement or a partial knee replacement?
Yeah, so first we look at the patient's overall joints that have, in it, say, a knee replacement, if their kneecap and their lateral compartments are okay or not. And then patients with pseudo-gout, chondrocalcinosis, or rheumatoid arthritis, or any autoimmune inflammatory disease are not candidates for partial knee replacement. So patients who have gout, pseudo-gout, inflammatory disease are going to have a little bit of disease in the other compartments. So that's what we look at. And we also, in younger folks, when the answer isn't as obvious, we'll get an MRI on their knee to look at the other compartments. If somebody's in their 40s or 50s, we're trying to just do a partial knee replacement. When patients are older, we can see that sometimes on plain x-rays or looking at their other joints or talking to them about a family history of rheumatoid arthritis or osteoarthritis. If they're prone to break down the other part of the joint, we're going to do a total joint replacement.
Thank you, Dr. Abidi. That's all for today. I'd like to thank everyone for joining us today. I hope you enjoyed the webinar and learned things about total joint replacement. The recording will be available on our website later this week on www.orthonorcal.com. If you have any additional questions, feel free to email us at marketing@orthonorcal.com or call us at 408-412-8100. Thank you and have a great day. Thank you, Dr. Abidi.
Yeah, thanks again. And I hope you guys learned something. Please check out the recording if you have questions and write down your questions and answers. And whenever you go into a doctor's office, keep a scratch pad with you, write down what they're saying, and then bring your questions ahead of time. It'll make the office visit much more productive. So thanks again.
Thank you.